Relapse after initial myeloma treatment can be overwhelming, but there are effective options available. In this video, we'll break down the treatments commonly used when a patient experiences a relapse after 1 or 2 lines of therapy, explaining how each works and what factors doctors consider when choosing the best approach. What treatment options are available for patients who experience a relapse after 1 to 3 lines of prior therapy?
So when we're talking about 2 or more lines of therapy, we're talking about two different treatments, meaning usually it's because the myeloma has relapsed after initial therapy. Most patients that have had 2 or more lines of therapy have been treated with drugs like lenalidomide, have been treated with drugs like bortezomib or Velcade. And in this setting, the FDA approvals include the CD38 monoclonal antibodies, daratumumab, and isatuximab, and also another monoclonal antibody called elotuzumab. So elotuzumab can be combined with pomalidomide or Velcade, I think, actually. And then isatuximab can be combined with carfilzomib or pomalidomide. And ixazomib is also an option here in combination with pomalidomide. And so essentially, when I think about patients that have had prior relapses, I'm always asking myself, what are they relapsing on? So for instance, if they've just relapsed on a IMiD-based regimen, then I might choose a proteasome inhibitor type based combination. If they're relapsing on a proteasome inhibitor-based combination, I might reach for IMiD-based combination. The other option that's available for patients with 2 or more relapses is CAR T-cell. So we have currently available 2 different CAR T-cell products. One's called cilta-cel or Carvykti, one's called ida-cel or Abecma. Cilta-cel is actually approved after 1 prior line of therapy, so you can get it after 1 or even after 2. Ida-cel is approved after 2 prior lines of therapy, so this is where you could consider either of these options. And then there are things that we use kind of off-label, things like venetoclax and for patients with T1114. So there's not exactly a FDA approval for these medications, and so we can always consider them.
The myeloma treatment landscape is changing very frequently. In the past 1 year, we've had CAR T-cell therapy approved actually in 2nd and 3rd-line therapies. So we know that based on CARTITUDE-4, cilta-cel, which is an anti-BCMA targeted CAR T-cell therapy, is approved for patients after first relapse. So as 2nd-line therapy, and ida-cel is approved for patients in after 2nd relapse. So essentially, they're able to get it in 3rd line. Now, that wasn't the case before last year. Traditionally, before that, patients were mostly able to get daratumumab, Kyprolis, carfilzomib, dexamethasone, so DKD combination, or daratumumab, pomalidomide, and dexamethasone DPD combination. So your traditional, at one time I used to call these agents novel therapies, and now they're sort of becoming your non-immunotherapy traditional options. So for a patient who's relapsed after, who's had their first or 2nd relapse, these options are still available. So for the right patient, we have the right and appropriate therapy actually, but we also have now CAR T-cell therapy available earlier.
How does the increasing upfront use of daratumumab impact its use at relapse?
What is the upfront utilization of daratumumab and in induction as well as maintenance? So I think our ability to use the drugs at first or 2nd relapse really depends on what they have been exposed to and also what they have been refractory to. Exposure does not necessarily equal refractoriness. So I think based on the Perseus data and even Griffin, many of us adapted using quadruplet therapies with daratumumab in the upfront setting in 2020, long before even Perseus came out. Many patients would get Dara RVD induction, a stem cell transplant if they were eligible, and then mostly Revlimid maintenance. I think the maintenance has not changed so much in multiple myeloma. So many patients at 1st and 2nd relapse are actually Dara exposed, but not necessarily Dara refractory. So I think for those patients, I would still think I would use daratumumab in combination with a pomalidomide or a carfilzomib in that setting. However, for patients who are on DARA-REV maintenance, or where the time to last DARA use and the subsequent relapse is very short, but if they're relapsing rather quickly post-induction, post-transplant, I'm actually shifting gear and thinking about more of an immunotherapy-based approach. And then also, I think belantamab mafodotin may become available in the near future. So that's going to change our landscape as well.
Belantamab mafodotin, or Blenrep, is now approved in combination with bortezomib and dexamethasone for adults with relapsed or refractory multiple myeloma who have received at least 2 prior therapies. Should all patients who are eligible for CAR T-cell therapy in second line choose that option?
I often get asked the question, hey, CAR T is approved in second line. Should everyone get it? And I think the answer to that is a very nuanced one. Ideally, yes, because CAR T offers a patient a treatment-free interval. It is an upfront investment of time, 2 to 3 months, with the pre-collection and then obviously waiting for the cells to be manufactured and engineered, and then actually the infusion and the post-CAR T care within the first 30 to 60 days, right? Or 30 to 90 days with frequent blood checks, frequent visits to your doctor. So it's an upfront investment of time, but then subsequently it offers the patients time off of monthly infusions. So, ideally that looks very wonderful. And as a CAR T person, I want to be able to offer that to my patients. But not everybody in second line is going to get CAR T. Number one is just logistics. Not every myeloma patient lives near a CAR T center. I know that there are mechanisms in place in bridging that gap, actually, and social factors as well. Having your caregiver, which we underestimate, actually, right? We underestimate the social burden of getting treatment for a patient. So practically not everybody's getting it, but then there's a risk as well with these therapies, such as the delayed neurotoxicity, such as the Parkinsonian features, and then lately there's an emergence of secondary malignancies that's coming out as well. Now it's really hard to pinpoint whether the CAR T is the culprit, or it's the prior melphalan, or it's the prior Revlimid the patient has gotten. Myeloma patients, because of the advances in therapy, are living a long time. During this time, they are getting a lot of treatments, which increase their risk of getting these secondary malignancies. So it's hard to pinpoint what exactly is the culprit, but I think that information should give us pause. It should give us time to reflect and pick the right candidates for second line therapy. And I often consider somebody who's younger with high risk disease or functionally high risk disease who relapses probably within 12 to 18 months post stem cell transplant as the main selection of patients for second line CAR T. Now, I think my answer, if you ask me in the next 2-3 years, might shift, because I know that there are strategies to enhance these CAR T cell therapies. So there is an off switch in case the CAR T cell causes a problem. As we wait for those new improvements in CAR T design come, I think CAR T second line is being given, but to a carefully selected patient population, keeping in mind logistics, hospitals' constraints, and social factors, and overall patient preference.
How are bispecific antibodies being used in early relapse?
Bispecific antibodies initially were approved for the treatment of late relapse refractory multiple myeloma in patients with at least 4 prior lines of therapy. But because they have been very effective in this setting, there has been multiple trials looking at bispecific antibodies in earlier relapse refractory multiple myeloma and even in newly diagnosed myeloma patients as well. And so there was one clinical trial called the MajesTEC-3 study that looked at patients with 1 to 3 prior lines of therapy, and patients were randomized to either receive a BCMA bispecific T-cell antibody teclistamab plus daratumumab versus standard myeloma treatments, namely daratumumab, pomalidomide, and dexamethasone, or daratumumab, bortezomib, and dexamethasone. And the initial results of this trial were then presented and really were quite astounding, as sort of a mic drop moment where we saw a significant improvement not only of progression-free survival, but actually overall survival in patients that received the teclistamab, daratumumab combination. It wasn't just a mild improvement, it was a pretty significant improvement in the magnitude of both progression-free survival and overall survival. And so based on these very positive results, the Food and Drug Administration in the United States reviewed the results of this trial very, very quickly. And in less than 60 days since their initial review, it led to the approval of this combination of teclistamab, daratumumab for patients at first relapse. So I think this is a really important moment for patients with multiple myeloma, because this provides another weapon against myeloma that's very effective, hopefully accessible to patients in need of these therapies at the time of first relapse.
Could selinexor be considered at this point?
Selinexor Velcade Index is actually approved to be used after, I think, one line of therapy, so it can be used pretty early on. Oddly, selinexor and dexamethasone, the two-drug combination, has to be after 4 lines of therapy in terms of FDA approval. I've actually had very nice results with, especially for patients that are trying to get to CAR T or something like that in the future. Sometimes tolerability can be a little bit of an issue with these medications.
We have other agents such as selinexor Velcade dex combination, or selinexor pomalidomide dexamethasone combination. So for those patients, I would even consider that in that patient population.
What's the role of alkylating agents in this population?
So when we talk about alkylating agents, I think the main ones that come to mind are going to be cyclophosphamide, bendamustine, doxorubicin might be the ones that come to mind. Cyclophosphamide is frequently used in combination with Velcade in a combination called VCD, sometimes called Cybor-D, and then can be used in combination with carfilzomib or even actually the IMiDs. So I think cyclophosphamide is one that we frequently reach for, especially if someone's experiencing disease relapse and hasn't had it before. Bendamustine, however, was something that I was reaching for a lot in the past, but in this era of thinking about bispecifics and CAR T cell, bendamustine is actually very toxic to T cells, and so if I think somebody might be getting bispecifics or CAR T cell in the future, I try to avoid bendamustine because it can be really lymphodepleting.
A PACE-based protocol is an intensive combination chemotherapy regimen used mainly for aggressive or relapsed multiple myeloma. It includes 4 core drugs: P, cisplatin; A, doxorubicin; C, cyclophosphamide; E, etoposide. Other drugs may sometimes be added to this base regimen to tailor treatment to a patient's specific disease or prior therapy. Is there still a role for PACE-based protocols?
I think there's always going to be a role for PACE. When I think of using PACE, I think of using it typically if somebody has a very rapid relapse of disease where chemotherapy is needed to get disease control. So this might be in patients who experience extremely rapid relapse or very bulky disease that hasn't responded to IMiDs and proteasome inhibitors.
What is a PACE-based regimen?
PACE is a chemotherapy-based regimen, and frequently we'll combine it with proteasome inhibitors and IMiDs as well. But this is where we're using drugs like cisplatin, etoposide, doxorubicin, cyclophosphamide in order to control disease. So it's a multi-drug, like a 96-hour infusion of chemotherapy. It's actually quite effective in myeloma at keeping things under control, but comes with a lot of toxicity, especially low blood counts, increased risk for infection, need for transfusions. And then we always get concerned that it could maybe impact the T cells, again, if we're thinking about future T cell collection. On the other hand, it's very effective at controlling myeloma. And so when we need quick disease control, it is something that we could consider. It is something that's difficult for people to tolerate over and over again. So usually we do 1, maybe 2 cycles of PACE to get disease under control.
What factors are considered when choosing a treatment at relapse?
We keep in mind several factors that help us decide what therapy is appropriate for a patient. So we look at the timing of relapse. How soon after their diagnosis or induction and transplant are they relapsing? Are they a functionally high-risk patient, or they are actually, biology-wise 17p deletion 414. So the genetics of the disease, the timing of the relapse actually plays a role in us deciding a therapy. The burden of disease also plays a role. Is it just someone who's having a biochemical relapse? And that means just the M spike or the light chains are trickling up slowly, right? That's a biochemical relapse. Now that relapse is very different from someone having a clinical relapse where they're presenting with hypercalcemia or new bone lesions or new plasmacytomas. Two different types of relapses that require two different types of thinking about it, right? And then what they have been exposed to and what they are refractory to. And other social factors that we don't talk about as much, so such as where does the patient live, how far do they live from an academic center, what is their social setting, do they have a caregiver. So I think several factors play a role. It looks very easy that, oh boom, I will do this and I will do that, but actually it's a very nuanced discussion between the patient and the doctor and the whole care team in figuring out what is the most appropriate therapy for a patient.
Relapse myeloma can be challenging, but understanding treatment options like CAR T therapy, bispecific antibodies, and other combination strategies helps patients and caregivers make informed decisions. Always discuss with your healthcare team to find the approach that best fits your situation.